Bismillahirrahmanirrahim. Shahr Ramadan Mubarak, everyone. We're in a blessed month. It's lovely to have us back. We've been quite lucky, actually, in March to be blessed by two webinars. We had Christopher Doyle earlier. And as you know, we have a very special guest, which I'm very, very honored to have today. And we're going to start, as we normally do, a little bit of an introduction. And it might be some of you are joining and don't really know what we do or what strong support is. So I'm going to give a brief intro to start. We start with, as we normally do, with verses of the Quran. It's also the month of Ramadan when the Quran was revealed. The verses I've chosen for us to look today are the essence, if you like, of when we talk about attractions or same-sex attraction within the Quran. Now, these two verses obviously talk about the people of law, but they're the same verses, as in God repeats this in two different surahs, two different chapters of the Quran, in which he's telling the people of law, you're approaching men with desire instead of women. Now, it's interesting that the verbs which are used here are verbs which are to do with an action. They're not verbs which are used to do with thinking. So it's like you're going to men or you're committing the act. It isn't so much about, oh, I'm having thoughts or I'm having attractions. What's mentioned here is the act. You're approaching men, and the differentiation here is shahwa. So both of the verses use the word you're going to men with lust, and lust being very different from love. So we're not talking about love here. We're not talking about romanticism here. We're talking about sexually driven lust and so on. So now what's interesting is what then happens after these verses is one of them says bal antum qawmun musrifun, and the other says bal antum qawmun tahjalun. And when we analyze this, a lot of the times when people come and in Muslim circles, they'll come and they'll talk about same-sex attraction. They might talk about it in an essence where it's somebody who is extravagant or is transgressing the bounds and is extremist. And that's the first verse where it's talking about someone who is kind of going beyond the limit. And that's usually how it's thought of. But it isn't thought of as in the second verse, where it's taught that, oh, people are ignorant. So God is saying here that people who are doing this are ignorant. What are they ignorant of? They might be ignorant of what's actually deep within. They might be ignorant of the society saying this is the way to live. This is how you should be doing. They might be ignorant of their own selves in terms of having the awareness of things and so on. So this is quite this is quite important that we make that distinction, and hopefully it is useful in this context when we're talking about especially clients coming and they're ignorant of maybe emotions which might be deep within. So people who don't know what we are a not-for-profit peer support group. We're based for Muslims, but just like this webinar, we're open for anyone. So we actually have people in our circles or people that we've helped which are non-Muslim. So even though it's a resource which we use Muslim texts, we use Quranic texts, we're very open to helping other people. And we realize this is more of a human rights issue rather than it being anything else than a human rights issue. So we help. If you're joining, you're of a different faith, you're very much welcome in this space. We offer 30-minute consultation. Anybody can access that. If you're struggling, go to website. We have a Calendly link. You can access that. We also have support circles for men, women, parents, and spouses, which are really discounted. They're discounted at £10 per month. And we've done that intentionally because we know we have people not just coming from Europe or US, we have people coming from all over the world, and we want to make sure that is affordable for people who are kind of coming from areas where they might not be able to afford such support. There's a special circle for Arab speaking men. So we have that for very large group of people who came to us saying there isn't any support for that population. So we have that on Sundays. I myself, I do coaching. So we have coaching, which is available on Friday evenings. And then, of course, we have things like this, which are webinars, or we do some type of collaboration, or even we do advocacy work in terms of making sure that rights for this population are protected. And, with the legislation or so on, that our voice is heard. Next webinar is Richard Cohen. So I would, really recommend people to attend that. That'd be on the 29th April. But also we've had, since we have Dr. Nicolosi on, we've had a lot of guests, and a lot of guests have mentioned his work. So, if you are interested, we had Andrew Rodriguez, absolutely fantastic, who I know, which I know is at the moment just finished his reintegrative therapy certificate or qualification, and he's fully qualified. He's doing that. He's been a fantastic help for us in the past. So good shout out to Andrew. We had David Pickup, which I know, done a lot of work with reparative therapy, has been kind of involved with Alliance and so on. Again, a really good webinar there. We also had the study, which I presume Dr. Nicolosi will mention, which Dr. Caroline Pila set, and this was done across 3 years. It was a longitudinal study, about 75 men, and they used scientific measures, looked at the psychometrics in terms of after each session, and that actually got published and was peer reviewed. So really, really good research, which was done across many years. And it was really great to have Dr. Pila on to share that with us. And then obviously we had last year, we had Michael Gasparo, which is obviously works with Dr. Nicolosi in Breakthrough Clinic. And we went through OCD, how common OCD is in this population, what it really means in terms of emotional integration, and kind of other types of. I remember there was mortification therapy. There was different types of things which he had discussed here. So a wealth of stuff. You can go to our YouTube channel or our Facebook channel, and you can see these webinars. They're available. So also, just to kind of give, what is available at the moment. Now, there was a lot of, it's been very hard, at least at this side of the pond, to get hold of some of the work. So what's really, really good news is, these two books, and actually I've got both of them. I'm halfway through the first one at the moment, The Best of Joseph Nicolosi. And that this is available. So if you are interested, this is available on Amazon, surprisingly. So I went to Amazon and this was available. And I do recommend it. Why do I say that? Well, in my own personal work, and some of you may have known, the first ever book I read on this topic was on book by Dr. Nicolosi Sr. On reparative therapy for the male homosexuality. And when I read that, there was a point there. There was subtleties there, like men with same-sex attraction either are they want to show their bodies, they're a bit narcissistic, or they want to cover their bodies. And I was the type that didn't like my body. I wanted to cover my body. And I was like, wow, this type of detail, this level of detail in a book. And, Dr. Nicolosi Sr. saw thousands of clients in his lifetime, which kind of shows the depths of the information which he produced. So it takes me, even though I'm a counseling student, it takes me 10, 15 minutes to process some of the words to really understand what is said in a very short time, to really see the depth of work. And I think I would argue Dr. Nicolosi is the only person who suggested a clinical approach to this, a unique clinical approach. So really pioneering stuff, something that really influenced my own journey towards this work in psychotherapy. So I'm hugely indebted to the work of Dr. Nicolosi, and I'm 100% supportive for this cause. So, it's, I consider myself really honored to have Dr. Nicolosi with us. This is a brief introduction. If he needs an introduction, but I'm going to give him anyway. He's a licensed clinical psychologist, clinical director at the Breakthrough Clinic in Southern California in Encino. He is the president of Reintegrative Therapy, which is also a nonprofit organization. He has provided expert testimony in multiple legislative hearings across the US to do with bans, as we mentioned earlier, in terms of legislation. He's appeared on different TV programs, written for the Federalist and Washington Examiner. He received his Ph.D. in 2009 from Chicago School of Professional Psychology. Now, if you want to know more about reintegrative therapy, a really good resource is odyssey.com. So if you go to odyssey.com and go to reintegrative therapy, you can see a variety of videos. And these are really good videos. I've watched them, and that they explain the reintegrative method. They go through actual case stories, and it's really, really great work. And if you want to kind of find out, okay, especially if you're familiar with the work of maybe Dr. Nicolosi Sr. and you're wondering, okay, what is the difference in terms of reintegrative therapy? What's the different approach? Then this is a fantastic place to start. Now, as we've mentioned, it isn't that this work hasn't come with controversy. It's come with pain. It's come with difficulty. And, I really, really want to applaud. I would applaud the whole family, Dr. Nicolosi Sr., and also Linda, who has helped with the books, and Dr. Nicolosi Jr. This family as a whole has stood out and said, no, we're going to fight for this human right. We're going to fight for the human right for people to be self-determining and access support and help in terms of attractions and in terms of looking at fluidity, sexual fluidity, in a non-biased way, in a scientific way, to do research. And I think, as you all are aware, the climate is so restrictive. It's so difficult to do scientific research in this area, and you face so much opposition. So example, we saw that the Reintegrative YouTube channel was taken down, and EMDR, which has the organization kind of not helping this population. I mean, if we put, and I really asked this, I even asked the professional bodies that we have here in Britain, BACP, I asked them, what do you do if a client comes to you and they say, I'm unsure, I'm questioning, I don't think that these sexual attractions define me. Do you tell them that they're gay? Do you enforce that on them, or do you allow them to explore a possibility? Isn't it really unethical if we just said to them, oh no, you're gay, you need to live with it? Oh, don't care about what your faith says, or what you think intrinsically. This is who you are and this is what you need to accept. I would argue that's conversion therapy, because you're putting your values on the client and you're not letting the client choose. And don't get me wrong, I get referrals from parents who would say, oh, can you see my daughter? And I'm like, well, if she wants to be seen, we see them. We can't, unless the person comes in with whatever they want to do, that's where we're heading. And that's where ethical therapy is. But what we're increasingly finding is, if I'm a client population and I'm not happy with my sexual or gender identity, as in it's, maybe I have a conservative worldview, maybe I have a faith-based worldview, my access to therapy is being completely obliterated by these laws. And it's extremely discriminatory to a very large section of the population. And I don't think it's a faith issue. Where we're talking about, we come from different faiths here. This is a human rights violation. This is a human rights issue. So, I really support the bravery and the honor and the courage to by Dr. Nicolosi, by his family, to continue doing this work. And we're all with him. We're all praying with him. Saying that, we're talking about new research. I know that at the moment there's again, they're continuing to do, the Reintegrative Therapy Association is continuing to do research. And I had the honor of seeing Dr. Nicolosi in IFPCC, where he was talking about the amygdala in terms of, kind of doing brain scans to kind of see what is difference in terms of attractions. And this is really, next level stuff. This is research. And if you are watching this and you do think that this work needs more research, it needs more discovery, then please do support this work. Please do donate to this work, and please, kind of put your support, in this case, put your financial support for it. So yeah, I will introduce Dr. Nicolosi. Thank you so much for being here and taking this time on, I know, a nice Saturday morning for you in California. So we're very, very grateful that you're here.
Thank you. Thank you. Thank you for that introduction. I'm so grateful, Ali, for your work and what you're doing here. And for each person who's showing up. I'm seeing people in the group numbers of people going up, the participants, and people from around the world. And I'm appreciative to each of you. So let's get started. And let's see here. I might be using some slides. Give me just a moment and then we'll get going. All right. Can you see this okay?
Yeah, it's great.
Great. Okay, good. So we're gonna get going, guys. We're gonna divide this into 3 portions today. So the first is going to be a basic recap about what reintegrative therapy is, the research, different directions we're going. So it's going to be a bit more heady and theoretical. Then we're going to move into the topic of attachment styles per se, and what we have used at this clinic to focus on something called a secure attachment style. And we'll talk a little bit about some of the research about that and how many of our clients report a spontaneous increase in heterosexual attractions. And then finally, I'll take your questions. We're going to leave a lot of time for Q&A. We'll get very practical. So we're going to start theoretical and just slowly move more and more practical throughout today. So, all right, let's get started. So, let me introduce reintegrative therapy and its evidence-based background. Reintegrative therapy is a registered trademark with the United States Patent and Trademark Office. Trauma treatment is the goal, and sexuality change is often the byproduct. That is really what we're doing. There are 2 published studies that were released in the last 2 years. The Pila and Sutton study, which some of you are familiar with, demonstrating reintegrative therapy's effects on males with same-sex attractions, and the Nicolosi and Rosick study, which demonstrated how the same approach was shown to be effective in the treatment of binge eating. So these are both very different presenting issues, but the underlying process called the reintegrative protocol is the same. We just focused on treating traumatic memories, and we noticed shifts in these different areas for people. The Pila and Sutton study was a large-scale longitudinal study. It was 75 male participants. The participants did not have to be men who wanted to go from gay to straight. And that, to me, is what's most interesting about this particular study. The inclusion criteria of the study was simply to be a man with same-sex attractions who was open to his sexuality changing and willing to undergo a trauma treatment. If a participant decided partway through the process, and this happened for some of the participants, if they decided partway through the process that they wanted to retain a gay identity, they were not dropped from the study. They were still included. So trying to force a change in one's sexual feelings might actually interfere with this process. So the participant's task was simply to work on resolving traumatic memories and just let whatever happens happen. So these were the results. After doing that, opposite sex attraction experiences increased statistically significantly with a p-value of less than 0.0001. If you know anything about statistics, you know that's a very powerful finding. Same-sex attraction experiences decreased statistically significantly, p-value of less than 0.0001. And sexual attraction identity moved toward heterosexuality. So what this reveals is it's not just an example of behavior modification that the authors reported. Attraction experiences were measured by measuring thoughts, feelings, behavior, and identity, multiple domains, showing that this was, in fact, true change. So in addition to sexuality changing, they also looked at well-being. So the well-being was measured using an instrument that's used widely across the United States called the OQ-45, or Objective Questionnaire 45. This is used in mental health clinics in all 50 states. And it measures the participant's psychological distress. So we're measuring distress here. The distress was at a 71. It dropped down to a 54, which is a statistically significant difference, also known as a large effect size. So not only were they seeing shifts in their sexuality, but their well-being was improving. So this is how reintegrative therapy stacks up to other therapies. We can now compare, for the first time, reintegrative therapy to treatment as usual, in other words, general psychotherapy. And I think what you're about to see not just speaks of reintegrative therapy, but the state of psychotherapy today. What is psychotherapy? How effective is psychotherapy? 37% of individuals in general psychotherapy are considered reliably improved by the time they end therapy, according to this outcome measure. And they've done this in multiple places, in multiple peer-reviewed journals. They've been assessing this using this measure. So just for a moment, seriously, I mean, really think about this. Imagine there's a hospital in your town in which only 37% of the people who leave it are reliably improved. Now, would you bring your loved one to that hospital? Personally, I would not. I would keep my loved ones so far away from there. And yet that is the success rate of treatment in today's psychotherapy. In contrast, 57% of reintegrative therapy participants were considered reliably improved. Improvements include increased functioning in social roles, improvements in quality of life, and improvements in interpersonal relationships. So what are the key conclusions here? According to the authors, reintegrative therapy interventions resulted in a remarkable improvement in well-being for men open to sexual attraction fluidity. And these are quotes from Pila and Sutton in their published article in the Journal of Human Sexuality. And sexual attractions are not immutable and can change as a byproduct of trauma processing. Now, there are some limitations to this. So this was a single group design, meaning it was not a randomized control trial. They only looked at one group of people. There was no placebo comparison group. Second is sexual attraction fluidity was measured using the SAQ, the sexual attraction questionnaire. That self-report. In other words, this is not a blood test we're talking about. We're measuring attractions and identity, which are subjective phenomena. So we have to measure using self-report. And then finally, the generalizability of data is limited because many of these participants were religious participants. They had some kind of a religious faith. So we can't perfectly extrapolate it out to the general population at this point. The Pila and Sutton study is available in full for free online. You can go to reintegrativetherapy.com and download the entire thing if you're interested. Okay, now, since we're talking about limitations, I think this is really important for the rest of our whole discussion here. Although the client sexuality shifts were quite significant, not every client reported a shift, and clients reported their shifts to varying degrees. So when we talk about changes in sexuality, we're not talking about flipping a light switch. Okay, we're talking about rotating a light dimmer, turning a light dimmer. We're talking about gradual shifts of varying degrees. It's different for each person. So it's important that we don't overstate or oversimplify these results. Everyone responds differently. No one can guarantee an outcome. If you're interested for more information, we have handouts available at reintegrativetherapy.com. And as Ali mentioned in my introduction, we talk about the distinctions between reintegrative therapy and so-called conversion therapy. That's all there. Okay, who's in the driver's seat of this therapy? And Ali alluded to this earlier about how many therapists now will suppress the person's right to explore heterosexuality. And in a sense, they are kind of doing a conversion therapy of their own, or they're attempting to. So the therapy is based on the principle that the client's in the driver's seat of his own therapy. A prior set of assumptions about the client's sexuality is not necessary. You can be religious, you could be non-religious, you could be on the political left or political right. It's all the exact same method. So right now I'm speaking at strong support where there are many Muslim individuals, but next month I'm speaking at the Catholic Psychotherapy Association National Conference. It's the exact same method. So a prior set of assumptions about the client's sexuality is not necessary. It's not based on social political ideologies. You could be pro-gay. You could be pro-gay and still use it and get the same effect. In short, reintegrative therapy is a methodology rather than an ideology. Here's another way to think about it. On the political left, the topic of homosexuality is viewed through a social political lens, social political identity lens. People are primed to think of it through that lens. We all have lenses. Everybody has a lens in which we approach topics. On the right, on the political right of the spectrum, when people think of homosexuality, they view it through a morality lens. And these are important lenses for people to look through. I think these are valuable lenses for people to have as they go through life. As a clinical psychologist, I am viewing this through an attachment lens. And that attachment lens is based on neurobiological patterns of activation, So let's get into those patterns. Let's talk about those patterns. On the top two horizontal rows, in other words, quadrants A and B, we're viewing arousal in homosexual men when viewing male sexual images. On the bottom two rows, in other words, quadrant C and D, we see arousal in heterosexual men when viewing female sexual images. There are differences in the brain. And it's very popular right now to say love is love, it's all the same, there's no difference. But the neuroscience reveals another story. Neurobiologically, it is different. So we're going to get really into that in a few moments. The authors of this particular study said, it's interesting to note that different neural circuits are active during sexual arousal in homosexual and heterosexual men. Although the amygdala differences we found are consistent with the hypothesis that homosexual men's brains show atypical patterns of activation in sexually dimorphic regions, these results do not paint a simple picture of homosexual men having so-called female brains. That's not true. It's not what we're seeing. So amygdala activation, this is an area in which we saw significant changes. Amygdala activation. The amygdala is pivotal in processing fear and shame. Fear and shame. Why is this region more active in these men with same-sex attractions? Especially in the moment, particularly in the moment of arousal. So I don't know exactly, but I can tell you this is what my clients tell me. These are direct quotes from my clients. Okay, here they are. So one man said to me, actually, multiple men have used this, I am attracted to men I'm afraid of. I'm attracted to men I'm afraid of. I don't hear a lot of heterosexual guys say, oh, I am attracted to women I'm afraid of. Another man said to me, again, this is a direct quote, I am drawn toward men who represent the kind of son my father wished he'd had. I'm drawn toward men who represent the kind of son my father only wished he'd had. The man I'm attracted to represents the shocking reminder of all that I believe I am not. These descriptions that my clients tell me seem to match up with psychoanalysis, or what psychoanalysis has been saying for 100 years. Now, this is all buried in the research literature. It's almost like you can't find it now, but it's there. Psychoanalysis had a name for this. They call this eroticized envy. Carl Jung, you may have heard of him. Anna Freud, the daughter of Sigmund Freud. These people talked about openly eroticized envy, that these men are attracted, and that might explain what we're seeing in the amygdala responses. Now, is this right? Is this theory right? Is this theory wrong? You decide. In the meantime, more research is being done, but I think it's an interesting area that people should have the right to talk about. Psychoanalysis has been saying this for years. By the way, and Ali mentioned EMDR earlier, and I really appreciate him doing that. Multiple studies have shown this. Consequently, other published studies have reported spontaneous sexuality changes as a result of this approach. But the media and psychological establishment refuse to discuss it. They just ignore it. The first one is a client who, with EMDR, just standard EMDR, had decreases in homosexual attractions, increases in heterosexual attractions. This therapist did EMDR on the guy's view of God. God, who's a very punitive God, okay, do EMDR on it. And it kind of shifted the guy's view of God. And that was just standard EMDR. The second study, by the way, these things are, I always try to use studies, and whenever I present, studies that are available free online if you Google them. So I really work hard to do that. Almost every study that I'm referencing today, you can find for free and full online. Another one interesting with Iranian women who were functionally asexual. They did EMDR on early trauma memories, and lo and behold, they started noticing spontaneous increases in their heterosexual attractions. Here's another one. One study examined women with predominantly heterosexual attractions. So they had both. They had homosexual attractions and heterosexual attractions, but up to 30% of the participants' attractions were same-sex attractions. Okay, so to be included in the study, you have to be a woman who has mostly heterosexual, but some homosexual attractions. Again, you can find these all for free online. When these women practiced mindfulness, a process called mindfulness, that's all they did. That was the only treatment intervention. When they practice mindfulness, which is to say, awareness of the present moment, non-judgmental awareness of the present moment. Okay, so I'm feeling this. Oh, I'm feeling a tension in my stomach. Oh, I'm feeling a dropping, sinking in my heart when I see that person. Like they're just focusing on being aware, non-judgmentally, just aware of their inner experience. When they practiced mindfulness, they reported significant spontaneous increases in their opposite sex attractions and decreases in their same sex attractions, results which were further reinforced by brain scans of those same participants. So OC here, by the way, look at what a clever way to hide the results. Talk about politically correct. I mean, man, if you want to get something into the research literature and get the peer-reviewed journals to go ahead and publish, you have to be very careful. So OC here stands for orientation consistent, which was their heterosexual attractions. And on the right, you've got orientation inconsistent, or OI attractions, meaning these attractions were inconsistent with who the participants saw themselves to be. And those attractions spontaneously decreased after practicing mindfulness. That's just from one intervention. Again, we have the brain scans, reinforced by brain scans of the participants. Those were really interesting. The changes occurred on their own. That's what's important, meaning the participants were not trying to change their sexual feelings. They shifted away in a spontaneous manner, which is called non-volitional. Okay. So let's go to that next slide. Okay, so now we're going from theoretical to the next part here. We're starting to get a bit more practical. So this is a graph. This is a very basic graph of something called the dynamic assertion protocol. It's a therapeutic technique I developed. It's a structured approach which helps clients remain assertive in their interpersonal relationships. If you look in the Peel and Sutton study, you'll find a brief reference to the dynamic assertion protocol. So it was the reintegrative protocol and the dynamic assertion protocol. And I'm going to explain it, how it works, and then we'll do some Q&A. So these are the basic steps of the dynamic assertion protocol. We basically have the client focus on a relationship with someone who he wants to get closer to. The client is invited to, basically he thinks about, okay, be the man that you want to be. And this, by the way, this could be with a man. It could be a man with a man. It doesn't have to be a man with a woman. In fact, we've had this. Clients who come in, they say, I want to be in a more secure attachment pattern with my best friend. Okay, fine. We'll use the same approach. In this case, because many people have been asking for exploration of the topic of exploration of heterosexuality, I'm going to focus this discussion on that particular application, but know that it can be used in any relationship. So the basic steps are, we have the client focus on a feeling in his body. So whatever that is, anger, sadness, joy, love, fear, whatever it is, and tune into it, feel it. And then that's in the upper left quadrant here. And then imagine that feeling expressing itself spontaneously in an impulse toward the other person. Imagine doing that. So I don't know if you can see my mouse pointer here, but it's kind of going down here. So we're going from here. So tune into your body and then imagine expressing it. And then hold on to the possibility that the other person is able to receive it, to hear you and understand you. And then how would you like to imagine that person responding? So what is their internal experience and how would they express that to you? And then drop into your body. What do you feel in your body once that other person has given you that response? Tune into it. And whatever that sensation is, imagine expressing it. And we kind of do this loop here. And my clients oftentimes have difficulty internalizing a positive response from the other person. So the hallmark of the secure attachment style. What's a secure attachment style? Let's talk about that. Let's define it really quickly and give you the basic hallmarks. So in the secure attachment style, which can be done in any relationship, it could be with your father or your mother or your sister or a person you're dating. In the secure attachment dynamic, the client trusts that he can regularly identify his needs, express those needs directly, and trust that the relationship can accommodate those needs, even if it's imperfect. Even if the person tries, but they can't meet your needs, trust that the relationship is accommodating or trying to. And optionally, the client can make and maintain boundaries if his needs are consistently not met. That's a secure attachment style. That's the goal of this technique. There are 4 attachment styles, and I want to make time for Q&A, but basically there are 4 attachment styles. The research has repeatedly demonstrated that the secure attachment style, which develops in early attachment security, we're talking infancy. It's starting, the cement is starting to dry early on. That attachment style of secure attachment is associated with better emotional regulation, better social competence, superior academic performance, executive functions, cognitive skills. We've been studying this stuff for a long time. One longitudinal study reported that participants who had been classified very young as having an insecurely attached mother at 18 months were more likely 30 years later to report physical illnesses. So that early attachment dynamic is very important, lowering stress, lowering cortisol, how we go through life. So we want to see attachment security. The technique is not to try to manufacture sexual feelings for a woman. That's really kind of the opposite of what we're trying to do. Okay, let's go to the next slide. So this is the sequence of feelings my clients tend to report from the left side of the screen to the right side of the screen. As the client develops a secure attachment pattern, he is more often going to be developing patterns of relationship at the beginning of friendship, and then eventually warmth, and then eventually affection, that's in the middle, then romance, and then sexual last. That's the sequence. Now, many guys who we call the ever-straight, the guy who doesn't have any heterosexual, any same-sex attractions, his sequence is usually from right to left. He sees a woman, whoa, she's sexually attractive. I want to walk up and talk to her. And then they go out on a date, and there's romantic feelings, and eventually it works its way toward friendship. My clients, it's usually the opposite sequence of development. From my clients, it's from left to right. At the end of the day, who cares? If the people are feeling the full spectrum at the end, it doesn't matter. Frankly, actually, developing feelings from the left side, moving to the right, usually you're going to get a more stable relationship in the long run anyway. Also, it's interesting that in Eastern cultures, even we're talking India, China, actually, this is more the norm, moving from left to right. That might explain why the divorce rate is so high in Western countries. It might be a contributor. I don't know. But my clients sometimes are discouraged. Oh, I just feel friendship toward her. It's moving slowly to sexual feelings. It's like, who cares? Great. You're building a solid foundation with a person. Yes, it's not resembling a romantic movie, but again, look at the divorce rate in the West. The results speak for themselves. So building a solid friendship, having a trusting relationship, going slowly in the development of these feelings, spending a long time in just affection, non-sexual affection. There's something to be said for the positive benefits of that. So in the development of this sequence, it's kind of like we're building out a bridge. We're building out the neural scaffolding, a different way of relating through those different stages. And so this is what it's like for a client. A client will feel usually, I can do friendship. Affection, I feel like I'm stepping on a ledge. Romance, whoa, I feel like I could fall. Sexual, I can't quite conceptualize it. So this image right here is the dynamic we want to avoid, where the client feels like he has to manufacture feelings toward the woman. like, oh, I have to have my sexual arousal strong enough in order to make her happy. And the man is putting pressure on himself. That's not what we want. You know, the emotions of anxiety, fear, and shame. I mean, if we're going to be blunt, it's very hard for a man physiologically to get into arousal when he's in those emotions. Fear, anxiety, shame will reroute blood away from the reproductive organs into the striated muscles, into the arms and legs. In other words, fight or flight. Your body's going to shift blood away from the digestive system. So the body's saying, why would I want to reproduce if I'm in fight or flight? So when my clients feel anxious, what's called an anxious preoccupation with the woman, oh, I need to make her happy. I need to generate arousal. They can't get aroused. No man can do that. What we want is a different dynamic where this woman is my partner, she's on my side, and we're going to explore this relationship together at a pace that works for me. When the client can trust that, then his odds of seeing shifts in his attractions change in his favor. There's a video of this. I've been very theoretical, but there's a video online. Go to odyssey.com, search for exploring my heterosexuality. You can see an example of this technique. I know I've been very, very theoretical today with everyone, but that's a very practical example. One thing we do at our clinic here that we're now beginning with reintegrative therapy is we have a dashboard, a bunch of psychological assessments that we do. Here's what it looks like. It's like the dashboard of your car, only more complicated. And each of these panels is measuring a different dimension of the client's inner world. So it looks very complicated, but we have here heterosexual attractions. There's homosexual attractions in the upper left corner. We have 4 subdomains. That's the stack there: thoughts, feelings, behavior, identity. And we have the heterosexual feelings here. And we're rechecking them with the same assessments every 6 months. So we have baseline, 6 months, 12 months, 18 months. And then we have the thematic content. The thematic content. So these 2 scales are measuring the directionality of the sexuality. This one is measuring the content: exploratory, impersonal, intimate, sadomasochistic. If you get into, we might do a whole talk just on this before long. We have gender identity. So a reintegrative therapist is measuring these things over time, and sharing the results with the client. So they're on the same page. So that's the basic concept of the dashboard. And you can see it's non-linear. I mean, it's very different for each person, very different. So visit reintegrativetherapy.com if you'd like to know more. Let's switch to Q&A. I see that there are questions coming in. This, for me, I think is the most important for our time today. Let me shift out of here.
Yeah, thank you for that presentation, and there's so much to take from that, and as you say, the latest research which you're doing in terms of neuroscience is fantastic to see that. So yes, let's start with the Q&A. So the first one saying, I don't have slides. So I think slides, hopefully you can see those now. So there's a question here, anonymous attendee who is saying, how do you respond to Gregory Cole's articles critically analyzing the study, claiming the study didn't prove anyone really changed, but rather it was temporary and the actual orientation didn't change?
Good. Okay. So and then there's a follow-up question to that person. Do you think, to that same person, oh no, maybe that's a different person because it says anonymous attendee.
One.
It could be different people. Okay. So, thank you. Okay, so Coles, as a blogger, he falsely claimed that he was a senior research fellow. To be a senior research fellow, you typically have to have a postdoctoral education. Coles, actually, all of his degrees are not in science; they're actually in English. So he falsely claimed that he's a senior research fellow. I wouldn't claim that I'm a senior research fellow, and I have a Master of Science and a Ph.D. and I've done multiple studies. So this is a blogger with an English background. That's Coles. Coles doesn't know how to read the studies very deeply and he doesn't have the research background to do that. But many people changed. And by the way, you can look up Coles's background. I think he works for the Center for Gender and Sexuality. But you can read it in his bio. No research background. People did change, and the results were longitudinal. So what's longitudinal? We don't know exactly what constitutes longitudinal in my field, but most people seem to say about 6 months, minimum to call something longitudinal. These clients were tracked for up to 2 years. Coles misunderstood the study and thought that, you have to be, that the treatment was 2 years. No, they were tracked for 2 years. So they could have left earlier, or they could have continued longer, but they checked from baseline to 2 years. Didn't mean the client was kicked out of therapy after 2 years. And people did change. I mean, the longitudinal evidence, I think, clearly shows that. And as I demonstrated today, there's many other studies showing how sexuality change is real, including if you go to reintegrativetherapy.com, I think it's on the science page, click on science, you'll get a bunch of studies that show that. Let's talk about orientation, because in this question, someone said, did the orientation change? So this is what I'm about to say is complex, but the question is complex, and I want to do the question justice. So let's talk about orientation. Okay, there's 3 problems with using the term orientation, and this is why I try to stay away from it. Number 1 is that orientation is non-quantifiable. What's an orientation? If you have 51% homosexual attractions and 49% heterosexual attractions, what's your orientation? No one knows. Are you a homosexual? Are you a heterosexual? Are you bisexual? What if you're 75% homosexual, 25% heterosexual? Now, are you then a homosexual? Are you a bisexual? We don't know. We don't have cutoff scores. What if you're 99%? What if you're 99% heterosexual, but 1% of your attraction is homosexual? Now, are you bisexual? It's very confusing. Without cutoff scores, we really can't make meaningful so it's non-quantifiable. It's not a stable construct because people's attractions can change, especially the client population we're talking about. So it's non-quantifiable, and it's not stable over time, the term orientation. Therefore, what that means is it's a non-falsifiable construct. A non-falsifiable construct. Here's an example. A client of mine will say, yeah, I was predominantly homosexual before therapy, and now I'm predominantly heterosexual after therapy. And people will say, you were always heterosexual, maybe your change wasn't real. It's non-falsifiable. So how do we know? So I prefer to stay away from the term orientation for those 3 reasons, and instead we should talk about sexuality. Over time, we're going to start to do brain scans, and that's going to help us look quantifiably one day, but we are just at the beginning stages of that. So that's my reaction to, that's my logical and personal reaction to the term orientation. I think everybody across the spectrum, political spectrum, should stay away from that because of the pitfalls.
Absolutely. And as you mentioned, seeing it as more of a dimmer, so seeing it more of a continuum rather than seeing it something which is binary and it's fixed rather than it being fluid. Thank you for that.
Thank you.
I notice people are raising their hand. So what you can do is you can raise your hand and speak, but just be aware this is public. So your name will show if you want to go in and speak. And people will be able to see your name, and this is recorded. So just be aware of that. And if you still want to speak, let me kind of just message me in the chat, and then we'll allow you that option. Hi, Michael. Michael's here. Michael's saying hello. So hello to you. So we have another question saying, do you think change is temporary? Actually, we just said this, right? Or on a continuum. I guess we've just answered that question.
Sure.
So we can. So the next one is: do you believe SSA men have high rates of ADHD? hence the high activation of the amygdala.
Okay. So ADHD is predominantly connected to lower levels of activation in the frontal lobes. The frontal lobes are administrative functions of the brain. Administrative functions are what is interfered with by ADHD. So I would be thinking more about the frontal lobes and the amygdala. So I don't know if that would explain it. I'd be skeptical. Certainly there's a connection with OCD. There's no question there's a connection with OCD. A study by Sanford et al. In the Netherlands showed that. But with ADHD, I don't know. My answer is I don't know.
Okay. We have a comment which is saying, "Far, this is so true. The fear comes first, then the sexual attraction comes immediately." And even looking at Dr. Nicolosi Sr.'s work, the first thing he says is when you have the attraction is fear, right? So the client thing before the attraction's coming in, he used to say, "Oh, it's because I don't know, I'm seeing somebody who is more masculine or whatever more than me." The first almost response before shock is fear. And that's really interesting how the amygdala is that, what you said of fear of flight response. And many people seeing that. So thank you. Dr. Nicolosi, what is the future of SOCI? I fear the options and freedom for SSA men will be completely taken away one day, and all non-gay affirmative therapy will be banned.
Mm-hmm. That's a good concern. It's a valid concern. I don't know the future. I know I'm committed. I'm committed to this work, and that's it. It's a lifetime commitment. So I think when more people are saying no, we will pursue our own goals. We want equal rights. If you guys can, I mean, now I'm in California, so now there are therapists who are affirming kids doing drag queen story hour, and that's not considered conversion therapy. But if an adult man says, "I want to explore heterosexual attractions, it's consistent with my values," they say, "Oh no, that's too extreme. That could be harmful." So I think our messaging needs to be on the offense. No, we want equal rights, and we're not going to back down. And we're going to pursue this. And this is a human rights issue, I think, exactly as Ali mentioned. And if we do that, I think the future is bright for us. I really think so. These studies we're seeing how sexuality change can occur spontaneously. I think the evidence is stronger than ever.
Thank you. And yeah, I second that. As long as there are people who are fighting on one side, I don't think they can really tell people how they should live their lives. So I don't really think that will happen. Next question, Doctor, can someone with OCD and SSA also find success in this therapy, or will OCD always make things difficult?
I think it's a very good question. Whoever asked that, I think there are probably at least 20 other people watching this right now who are asking themselves that exact same question. So I'm glad for that question. 1/3 of my clients meet the diagnostic criteria for OCD. When my father passed away and I started taking on his clients, which talk about a randomized sample, that I didn't see that coming, I administered to all of them the same OCD assessment, all of his clients, 1/3 OCD. And there are many therapists who are seeing this. The Sanford et al. Study showed that there's a big link. So I want to talk about why we think there's a link, and then let me address the question real quickly, and then let me get into why I think there's a link. So the question was, will OCD, can a person find success in this therapy if they have both? Yes, but you have to work hard. You have to really work. No one, forget SSA, just OCD. No one sees a big shift in OCD without really working on it. So you gotta really work. And yes, OCD will make things more difficult. That's a fact. So here's why I think there seems to be a connection. And it's multifaceted. the evidence suggests that if you actually meet the diagnostic criteria for OCD, it is very likely that you have a first-degree blood relative with an anxiety-based disorder. So there is for sure a genetic component. For more than 50% of my clients, that's on the maternal line. And so that might partially explain what my father had mentioned with the over-involved intrusive mother who's higher anxiety. She has her own OCD and she's using the son to regulate her anxiety. No, don't do that. Don't get your shoes dirty. Do this other thing. No, you have to look perfect. You're gaining too much weight. You're doing the, and like it like puts so much anxiety on the kid. Now the poor kid's got the genetic component and he has the environmental stimulus of anxiety. And so he's hyper fixated on not making mistakes. So there might be a contributor in that regard in relationship to the family dynamic. But a person who has OCD, actually, let's use a person who doesn't have OCD. When a person doesn't have OCD, that person makes a mistake, oops, they maybe think about it once or twice later, and then they let it go. The person with OCD replays that event 49 more times in their head about how they failed, how they made a mistake. And so they're constantly reshaming themselves, constantly going round and round in their mind. And so what OCD does is it slowly erodes a man's confidence. It erodes a man's ability to make decisions, to be comfortable in his own skin. He's always self-doubting and questioning himself. And then along comes a good-looking guy who looks comfortable in his own skin, who looks decisive, who makes decisions and moves on. And they go, wow, that is the guy who has what I don't have. And there's that facilitates that sense of, wow, he's really on a higher level than me. And so we've got to work on that OCD. It's really important. Many clients who have OCD, what they notice is when they treat the OCD, they're not trying to change their sexuality, but they notice the sexuality shifts as a spontaneous byproduct. So to make things more complicated, we have OCD, we have SSA, and we have something that people would nickname online HOCD. And there's 100,000 pages on the internet about HOCD, which is a little adjacent to this, but it's like, was that a gay thought? Was that not a gay thought? I don't know. And then they get like into this anxiety. Oh, I need to push that thought out of my mind. If you look at people who are the XX gay, okay? They say this therapy didn't work, or I did this religious counseling, it didn't work. If you look, many of those people just had OCD. I'm not saying all of them, of course, but many of them had OCD and they were in such terror. Oh my gosh, I might have a homosexual thought. It was like terrifying to them. And the therapy was actually, in a sense, kind of making it worse because it was compounding the fear. Oh my, I can't have those thoughts. I can't look at that. And these people were just miserable, and understandably so. So I hope that helps. Let me grab something from my bookshelf that might be helpful. 1 second here. I've used this with 100 men at my clinic. This is the mindfulness workbook for OCD. I use it all the time. I say, go through a chapter a week. Let's review it, do the exercises. But reading about OCD is like reading about going to the gym. It's not going to make you stronger. It's about getting on the machines and doing the work. You cannot think your way out of OCD. Okay. If thinking could have gotten you out of OCD, you wouldn't have been here because you think so much if you have OCD. People with OCD think too much and do too little. You need to do more and sometimes think less. You just need to do the exercises. There's exposure exercises in here. There's a mindfulness meditation. It's a fantastic tool. So you need to do more, think less for some of you. And that is a powerful tool at decreasing the OCD.
We have a testimony here by Joseph Scambra, who says, would Dr. Nicolosi, my SSA and OCD decrease? So we have someone there affirming what you've just said there. So that's fantastic. And I can vouch for that. Even in our clients that we see, there is a high presence of OCD in this population. So that is definitely true. And, you know, when we talk about SSA or a byproduct, we're talking about comorbidities, and it's never just one thing that you're working with a client. It's a variety of things. So thank you for that. Can therapy help change a severely anxious attachment style, or is it too difficult?
Let's go back to the light dimmer thing. So can it help? Yes. To what degree? I don't know. And we need to start with diagnosis. If you were my client, the first thing I'd say is let's diagnose. What is this severely anxious attachment style? Is it OCD? Is it social phobia? Is it generalized anxiety? Let's see. Maybe we'll find some different angles. So I'd put the person on the dashboard and look at what's going on. And yes, there are certainly ways to decrease anxiety. The Wall Street Journal yesterday, front page, had an article about how exercise is just as effective as medication for treating depression, which we also know works with anxiety. We know that with anxiety, depression, OCD, exercise is pretty much just as effective as an introductory dose of Prozac. And so if you are highly anxious, working out is one of the very best things you can do. Does that mean you should lift weights, you should run, you should swim, you should bike? Frankly, it doesn't seem to matter. Doing something that you love and getting yourself into doing and not thinking is a great thing. So yeah, I think people can really see a shift. If you get a good diagnosis, if you're taking care of your health, we might want to consider medication, possibly. Mindfulness meditation is hugely helpful. A faith and meditation, a spiritual practice, is fantastic at decreasing anxiety. So these are all tools at your disposal, and there's no reason why you shouldn't be using multiple tools at the same time.
It's interesting how exercise correlates with what you're talking about, somatic experiencing and or body work, that with exercise, you're engaging the body, and it's not that you're just the same mode. So it's nice how that correlates. So we have another question, please, by Joseph Canberra. He said, please comment. We can agree that sex is more immutable characteristic than sexual orientation, yet LGBTQ activists and much of the general public celebrate sex changes even in monros, but not in changes in sexual orientation. Even in minors. So there's, but not changes in sexual orientation. So I guess that's what's saying is that a sexual fluidity change isn't really something which is celebrated. And yeah, we see orientation as immutable.
Mm-hmm. That's right. I totally agree. Totally agree.
Yeah. Next question is, when does a person know he is ready to explore his heterosexuality, and how should one deal with fear around this topic?
I think that's a great question. When? I think the client has to be, depends on the context, depends on the client, but I think thinking about that sequence is really important. So when a person says exploring his heterosexuality, can you develop a secure attachment style with a woman in friendship and affection? Can you do that? That's the fundamental. We should start with that before moving to sexual. Can you be your authentic self with this woman? Can you be unguarded? Can you, do you feel like you are in your masculine self? Can you be that way with her? Those are some questions that a man should be asking himself first. Can you develop a trusting relationship with a woman? Those are the fundamental questions that have to be addressed. So that, I think, would be a good way of dealing with it. And then the secondary question was, how do you deal with the fear? So I don't mean to sound like a broken record. I would wonder, and I don't know for sure, but I'd wonder if there's some OCD. I would want to get an assessment, because if there is, we would do some of this work. We do some of this by John Hirschfield is this book. And we would explore, one of the techniques is writing out your deepest fear of being rejected by a woman and feeling inadequate. And I try to assert myself, and it completely fails miserably. Like this, for my clients, that is their deepest fear. I failed the woman. This is it. All the bullies in school were right. I don't have what it takes. And that is devastating for them. So a technique is we call it scripting, where you write out your deepest fear and you expose yourself to it in consistent increments. And doing it in those specific increments often desensitizes a man to that fear. I'm oversimplifying it. I think it should usually be done with a therapist. I worked with a client who did it wrong, who did the technique wrong, and he was shaming himself. That's not the purpose of the technique, to get you to read it and shame yourself. That's not the purpose. It's written in such a way to activate anxiety and fear. Now that you can desensitize yourself to. Fear can be desensitized. Regardless of your fear of heights, fear of the dark, fear of disappointing a woman, fear of whatever, going to the gym and being in a locker room and being uninhibited, there are ways to desensitize fear. So to answer that man's second question, it depends on the context and whether or not he has OCD.
Thank you for the scripting technique, and how, again, reminder of how important dealing with fear is in this work. There's a comment. Yes, absolutely, Dr. Nicolosi. This is divorce rate. This is what you were saying in terms of divorce rate in our community is extremely low. However, their children and grandchildren is the complete opposite. Massive high divorce rate of those raised in Western nations. And we have seen that there is a cultural shift even in faith communities, where the divorce rate is probably now going up in terms of that. But I do see your point of communities which are less attraction based. So, over here it's like, oh, I'm getting married because the girl's really hot or she's really pretty, as versus to I'm getting married because I need to find a partner who's going to stick with me for life. And the different kind of ideologies, thinking patterns, and kind of coming to that point. And we have seen it time and time again, where we first have to build a friendship and then the attraction comes later, versus to men, as men, we're very visual. So when we see something, we're triggered, and that's not the way this journey kind of works. But yeah, I can understand where Adam's coming from and Dr. Nicolosi is coming from.
Can I say something real quick? I think that's a really important distinction. Many men will try to compare their level of homosexual attraction to their heterosexual attraction, or the jolt they suddenly get with a guy versus their feeling toward their girlfriend. It's apples and oranges. And let me explain why it's apples and oranges. First of all, for my clients, the somatic experience of SSA is different from OSA. For my clients, I can't speak to every man, but for the hundreds of men I've worked with, the SSA moment is a contraction in the chest and a genital surge that's sudden. Whoa, look at that guy. Whoa, wow, ooh, they say. Versus the heterosexual feeling, which is an expansion in the chest. This has to expand for a while first, and then the genital feeling comes later on. And they usually don't go suddenly together. In the SSA, it's the sudden tightness in the chest and genital burst all at the same time, versus the staged out feeling for the OSA. And so there are differences, and this is more of a slow burn, and this is more of a sudden jolt. The average, they were trying to get numbers in the United States, the average gay man's number of sex partners. And they found, now, two things very important. They found it was between 250 and 1,000 lifetime rates. Lifetime rates. Now, that's very important for two reasons. Number one is that number is so high. And number two is, why can't we get a lock on the number? Why is it such a broad spread, 250 to 1,000? We don't even know. Many of these men can't count them anymore. They don't remember them. They're saying, well, what counts as a sexual encounter? And so there's different definitions of that. So in the SSA world, sudden jolt, and the numbers show it doesn't tend to last that long. And versus the heterosexual, it's a slower burn, it's more steady, and you're not going to get the genital surge usually first. And that may explain one other thing: ooh versus ah. For men being attracted to men, it's ooh, look at that guy. The ooh is the tightness in the chest, versus look at that woman. Ah, wow, look at her. And that's the expansion in the chest. It's a different feeling. That amygdala is not firing in the same way. So anyway, I just think it's important for all of us to know we can't just make an apples to apples comparison.
Beautiful. That's a beautiful explanation between the difference between the attractions and how that's experienced in the body versus something which is jolt-based, fear-based, and rather something which is a slow burner in terms of love, I would say. Thank you. Is it normal to experience feelings of depression when stopping SSA behaviors and healing trauma?
Yes, absolutely, because the underlying affects are starting to come to the surface. So yes, absolutely, especially when the client was using sex to get out of his negative underlying feelings, to avoid that conflict at work, to avoid that another disappointing conversation with my mother, to another night, a Friday night, and I didn't get those return calls from my friends, even though I reached out to them. Oh, I know, I'll go on Grindr and use sex. So they're upregulating. So the jolt that I described earlier is an autonomic sympathetic activation of a jolt. And the depression is it's a pervasive autonomic parasympathetic that the person goes down into. And like, he's not using the compulsive behavior to jolt himself out of it. And so, yeah, he's going to have to go into the trauma memories, clear out the trauma memories. And what we generally see is that issue will resolve.
Mm-hmm. Yeah, so it's something that's always there, but he's not aware of it as much.
Yeah, that's right.
So we have a comment here about you've not mentioned about female sexuality is applicable to females as well, and I guess I'm curious as well, because some of what the model has may be comparable, but not fully. In terms of female sexuality or female same-sex attraction.
Yes, so female sexual. So we see that the occipital lobes in the back of the brain, that's visual centers, and the pleasure centers are toward the center of the. I actually have a brain thing. I don't know if you guys can see it, but anyway, so they're wired totally differently, and males have 5 times more connection between the pleasure centers of the brain right here and the occipital lobes, the visual centers of the brain. So for men, it's a very sudden it's a sudden jolt, it's very visual, and for women it's more relational. We do see that sexuality shifts are greater, come more easily for women. I think we see it comes more easily for women, and that's the work of Lisa Diamond. You can always look up Lisa Diamond's work on this. Non-volitional sexuality change. She also that was the brain scan study I referenced earlier. She was a co-author of that. But yeah, I think it can change, and it can change more easily for women because it's so relationally context dependent. Versus for men, it really is like a visual jolt. Yeah.
Thank you. To what extent are there healthy male friendships key, even with the men we are attracted to initially? So what extent are having healthy male friendships key in this work, even if we were attracted to them initially?
Huge. A man said to me yesterday afternoon, he said, I hunger for, and he said, it's not even necessarily sexual, but I hunger for a man's attention. I want to connect to a man. I said, where are your male friendships? He said, non-existent. I said, you're like a guy who says, oh, I'm so hungry, but he doesn't go out to the store. Like go there are, if you're hungering for male attention, affection, approval, the male friendships are a very, very powerful way. If you didn't have SSA, I would say the same thing. Male friendships are crucial. I don't know where I'd be without my male friendships. They're so helpful to have a group of guys who you can be your total self with. They can call each other out on things lovingly, and they're there for one another. It's a stabilizing influence in a man's life. And we've lost that in the post-industrial society, and now in the post-pandemic society, where we have all been atomized and we're all separate, individual. And so to answer the question, it's crucial.
Thank you. At what age can a person start? My son is 16. Also, does the person have to be willing to change?
All of my clients are 18 or older. I don't know. There are different states and different therapists. So I'm not sure if about 16. But does the person have to be willing to change? The person has to be willing to work on something. So the client's in the driver's seat. He should have something that he wants to work on. Otherwise, there's no point. Therapy is a waste of money.
How do you respond to many former reparative therapists, such as David Matheson and many others who left the field? They claim only small minority experienced long-term change. How do we respond to these heavy critics?
Okay, so we've got to look at the long-term effects of this work, longitudinal studies. You're looking at the Peel and Sutton study. You're looking at Jones and Yarhouse study. If we want to really look long-term, let's see. There are the studies that would say that sexuality doesn't really shift as a result of the therapy they're not really focus on specific therapies, like here's a particular treatment modality, and they usually lump in very broad things. So the Shidlow and Schroeder study, which would be a study that would say, oh, the changes aren't really lasting. Shidlow and Schroeder study were non-representative, and there was a heavy selection bias. So a non-representative sample is when you say to people, hey, did you not have a good experience in this therapy? Well, then come to us. Like, they recruited in gay bars. They recruited by posting things in gay bars. That's not a representative sample. So this question about small minority experiencing long-term change, that question is about requires a representative analysis, and we really don't have that. So the pro or anti studies are not really doing that. I think we'd have to really focus in on a particular treatment modality and analyze the percentages. And so, yeah, the critical studies are lumping in. Did you go to a Bible study? Oh, did someone pray for you? Oh, they did, about your sexuality? Okay, that's conversion therapy. That'd be the Williamson study, the Williamson Institute that did that. That was, again, non-representative. So we need to do higher quality studies.
Thank you. I think this has been kind of answered. Do you believe most people with SSA have comorbid disorders such as BPD, bipolar, OCD?
Much of the research says yes, especially OCD. Yes.
Thank you. Thank you for the presentation, Dr. Nicolosi. I just wonder if there, in any case, even in a small percentage, when the integrative, maybe reintegrative therapy decreases the heterosexual attraction tendency, instead of increasing the SSA, client becomes more firm with his or her homosexual attraction instead. So you're doing the therapy, but actually, the feelings of same-sex attractions are increasing.
It's possible, but unlikely. However, I can think of one man in my practice now who might resemble that. There's a man in my practice who he joined a doctoral program. He moved to the other side of the United States. He's alone. He doesn't have his male friends. And right now, his SSA is going up. And if we use when we use the dashboard, it went up. That does happen. That can happen. So I don't know if it's the therapy causing it. I don't know if it's a state or a trait. So is it possible? I don't know what the therapy would be causing it, but it's certainly possible that the person could do the therapy and that at some point in the therapy say, no, I want to have a gay identity, or my heterosexual attractions are weaker. That is possible. Yeah.
There's so many variables, right? Anything is possible in that sense. Is it possible to do EMDR alone by yourself?
The creator of EMDR, Francine Shapiro, would say it really wouldn't be EMDR therapy if you're doing it by yourself. There are techniques you can do on your own. Bilateral tapping, she said, could be helpful, and thinking about something positive, like if you want to lower your anxiety, that's one thing that you can do. But tackling trauma memories is best done with another person.
Thank you. Got a comment saying, your studies are amazing. Just wonder if there would be any way to partake in your process in a cheaper way, since in the place I live, the cost for a session is quite expensive in comparison. And then someone's commented, adding countries where online transaction is basically a problem, example, Pakistan and Iraq.
Mm-hmm. We're now in the process of training therapists in different countries. Slovakia, we're going to work on Latin American countries in this next year. We're starting to translate reintegrative therapy into Spanish. And so we hope to do that in the next several years. There are research studies, we do research studies from time to time. There are some cases where we might even pay you to do some short treatment interventions. That is actually possible. And we might be, as I mentioned, we might be doing brain scan studies in the future. So these things are definite possibilities.
Thank you. Another comment, keep up the amazing work, Dr. Nicolosi. You're doing amazing and incredibly important work for our community. Please don't give up. Question, I have attraction to specific body feature and I don't know why. The feature is very specific that if it changed for a small bit, it doesn't attract me anymore. So if that feature changed, doesn't attract me. I can't think of anything in my childhood or anyone who had that feature. It could have been my father, as I've seen old pictures of him, but I'm not sure if that was the reason. My relationship with my father when I was young was bad. What could be possible reasons for attraction to a specific feature? I'm guessing this is a physical feature. He's added, I started to work on developing that body feature and I got attracted to myself for some time. When I look back in the mirror, by time that attraction got less, but it's not gone. So what he's saying is he tried to develop that feature himself in his body, and but that attraction still didn't go away.
Okay, so there are several. This goes back to the dashboard. Is this OCD? Is there body dysmorphia? What's happening? So I would want to know about that. There are different things that people have done, my clients have done. We would use a reintegrative protocol, probably on that body part. That could be very helpful to see what's going on in you. Many of my clients report that the thing that they're attracted to, if there's great specificity, it's something that they themselves feel lacking in. So developing whatever that part is usually decreases what they call the eroticized envy. So that might be what we're looking, what is helpful, as it was mentioned. For some men, it is something called mirror exposure. Mirror exposure is a technique where you look at yourself in the mirror for specific periods of time. And this is done for body dysmorphia, for shame, and well, mostly for anxiety. But it's 7-minute increments several times a day where you look at that part of your body and you just look. Don't do anything. Don't do anything. And that jolt will go up and it will usually go down. And whatever the body part is that you're attracted to in yourself, just look, 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 and eventually it becomes boring. And I have multiple clients say to me, by the way, I have one man who was attracted to his own chest hair. having his shirt unbuttoned. And so his job was just to look for 7 minutes, 7 minutes, 7 minutes. And he said to me after 2 weeks, Dr. Nicolosi, this isn't doing anything. I'm frustrated. I said, keep going, keep going, keep going, keep going. Do it in the increments I mentioned to you. Do it. And then eventually, after a couple of weeks, then he saw a real shift. And he said, it's like basically gone now. That might be something. But usually the body part represents something that the client has not integrated into himself. So, for example, I'm going to make something up. If it is, I don't know, wide shoulders or something, the client doesn't really feel, even if he develops his own shoulders, that can help, that usually helps, but he still doesn't feel like he is in ownership of his body. It feels other than himself. And so he needs to learn that he needs to, through exposure, that can help him take ownership that, okay, this is my body. I don't, the psychoanalyst would say the exotic becomes erotic. The exotic becomes erotic. People find things erotic that feel really strange and unknown and disowned. So when you take ownership of it, usually it drops down. And mirror exposure can help.
Thank you. Conscious of time and seeing how many more you would like to take. At the moment, there are quite a few. Or if you are you okay? Are you okay for this? Yeah. Hi, Dr. Nicolosi Jr. Thanks for the wonderful presentation. I have 2 questions. If a client develops OSA after therapy, is it a sustainable, like would they relapse and so on? So that's the first question. Second question, 2 men exposed to similar developmental trauma and later have low self-esteem and shaming themselves, considering themselves inferior, but one of them develops SSA and the other does not. So there should be something more in development of SSA in addition to childhood traumatic experience.
Okay, so let's start with the first question. If a client develops OSA after therapy, is it sustainable? Could they relapse? It is possible. As we talked about, sexuality is fluid, but we would want to know what's going on in that relationship. So for some of my clients, they will be performing sexually with their wives fine, but there's one time where they fail and they feel like a loser. And then that happens to them the next time and the next time, the time after that. So we want to look at what is that specific context. Why was your attraction high, and then why did it plummet? So we want to explore what that is. For many of my clients, that is a feeling of emasculation that shuts them down, and they go into a shutdown experience. So it's possible. We need to explore why. And then the other question about 2 men exposed to similar developmental trauma, and they have low self-esteem and they shame themselves, they consider themselves inferior. One develops SSA, the other does not. And then it said, should there be something more in the development of SSA in addition to childhood or traumatic experiences? So we also need to account for the subjective experience of trauma. 2 people can go through the same trauma, but one is more traumatized than the other. Now, why is that? 2 people could be in a burning building and, oh my gosh, and we have to run out of the burning building, and one is traumatized, the other they're traumatized, but not as badly. So temperamental sensitivity. So when we come out of the womb, some of us are just more temperamentally sensitive. So temperamental sensitivity, earlier experience of trauma, we see that parental malattunement, maternal malattunement, specifically a traumatic, a malattuned mother who overstimulates the child or neglects the child seems to increase the probability that the child will be more sensitive to trauma in later developmental experiences. So that's, and remember the age, the 2 boys may not be at the same age. A traumatic experience for a 2-year-old is different than a traumatic experience for a 10-year-old. So very, very different. Gender identity is really peaking. Gender acquisition, gender development is around 2.5, not 10. So you're going to see different defenses. a boy who's traumatized at age 10 is more likely to use intellectualized defenses around the trauma. He'll kind of think about it logically and detach. A 2-year-old can't do that. A 2-year-old has to dissociate or disidentify. Those are the defenses that a 2-year-old would use. So there are several factors.
Thank you. We have a testimony says, I will affirm some of this by personal experience. I've been working with a therapist on some trauma and self-hate issues, and a woman walked into my life a couple of months ago and ended everything about myself or about care myself, scares the hell out of me, but also feels right every now and then. So we have that saying how much trauma and self-hate work is still consistent in this work. Thank you for that comment. Other than ERP, not sure what that is, maybe EMDR, I'm not sure what ERP is. What else is effective for severe OCD? What do you think about being passive, just not responding to my OCD, so just being passive to the OCD thoughts?
Good. So ERP stands for exposure with response prevention. So I'm going to put myself around the thing that scares me and just not do anything. If I'm scared of a spider, I'll be in a room with a caged tarantula for 5 minutes and I'll tolerate it. That's ERP. And so ERP is excellent for severe OCD. So when this person said being passive and not responding, I would say just make a tiny modification to what you just said. Not being passive, but observing my own OCD thoughts. And that's mindfulness. And we have a whole video on that called Mindfulness Changed My Sexuality. Go to the Odyssey page, odyssee.com, Odyssey, and type in Mindfulness Changed My Sexuality. It's our featured video right now, and it talks about that. So mindfulness is very close to what you're describing. And it's excellent. I mean, this book has there's an audio recording that comes with it by the author about OCD. It's an audio recording, mindfulness for OCD. So really getting into the world of mindfulness, practicing it regularly, has been shown to be very helpful for decreasing severe OCD. And also, I'm not your medical doctor, but if you were my client, I'd say just go get out of the house, just start lifting weights, go for a run, go swim. The weather is beautiful. Like, get out of your head. You're thinking way too much and doing too little. Just get into that mode. It takes work. It takes practice to get into that pattern. But when you're in that mode, it gets you, there's freedom getting out of your head.
Thank you. As you said, the change of sexual attraction is byproduct of reintegrative therapy to treat one's trauma. Then can we say that trauma is one of the factors that directs or forms one's orientation, sexual orientation?
And absolutely, totally, absolutely. There's a big study that's been buried in the research literature about how early trauma increases the risk factor of being transgender. Now, no one is talking about that, no one. But since I mentioned it, I may as well. I always feel a responsibility to provide citations when I make comments like this. So let me get the citation on that. 99% of the people don't care, but I'll look it up while we're talking and try to find that.
That's okay.
Big study.
And that's what we sometimes get from the other activists, right? They're saying that trauma, it's always trauma, and but actually, even in my work, it was the difference between big T and little t trauma. So sometimes it's not trauma in terms of, a single event has happened, but little t trauma of absence. So if you've never had male friendships, you've never had an active father or a loving mother, the absence of that becomes little t trauma, which then becomes significant. Because I think a lot of the times when people think of trauma, they think of a single traumatic event as opposed to something which is, you know, as we were saying earlier, in terms of depression is like a continuum. It's always there.
Yeah, absolutely.
So
can I share my screen for just a brief moment?
Of course, yeah.
Okay. So quick screen share. Right, here we go. So here's one. I don't know how much you guys are interested in the studies, but here's one. You'll never hear this in the media. The Journal of Sex and Marital Therapy, a prominent study, expressed emotion in boys with gender identity disorder. Basically, when looking at boys with GID, something like 53, let's see, a huge number. So basically, these kids were, the boys with GID, and you can see where this is Owen Anderson, Kenneth Zucker, they were not able to express their emotions in the same way. There's another one right here. We're trying to link trauma. We're talking about trauma and sexuality. So here's another significant one. I'm going to share my screen. 53% of boys, 53% of boys with gender identity disorder had a mother with full-blown borderline personality disorder.
Wow.
53% of these mothers with GID, compared to only 6% of the control group. So that's like general population versus these boys. So there's many studies showing this. We're just not being told. The media and the psychological establishment are just silencing the data.
Absolutely. Yeah, there's so much literature in terms of early childhood impact of gender identity and sexual identity issues later in life. Thank you. Do you think that SSA itself is a fetish, hence why it's more powerful than OSA? So would we say the attraction is a fetish?
For some people, it is. And again, this is why we can't use the term orientation, because how many fetishes do we need before it's an orientation? How many, what are the angles of a fetish? We don't know precisely. I don't know precisely. But there's a strong argument that it's not that different. And Michael Gasparo has discussed this topic in depth in his research on OCD and SSA. And if you're interested in watching his talk, he gave one at Strong Support, which is I believe, in your archives here, Ali, and then also at IFTCC. So if you look up search Gasparo, OCD, and same-sex attractions, you'll find his talk, and he goes into the literature on this. And so he makes a pretty strong argument that approximates what that person is asking. So there's a strong argument for that.
Thank you. There's more questions on OCD and attractions, and I think I don't know, so this one is saying, how successful have you been treating OCD with SSA? I think that's, I'm not sure what all of that, maybe he's saying, how successful have you been treating OCD and SSA? Maybe, I'm not sure what that question is really asking.
Let's assume that's
let's
the question.
That one.
Okay.
This is very similar as well. We've talked about this in terms of how do you differentiate between OCD and attractions, and I guess we've kind of discussed that. Someone's saying they're available to be in a test, willing to be part of it, but accept this. So how do people, if people want to help in this study or research, how do they reach out to you?
So we have a couple research projects that we're working on. They're in various stages of development. So Ali, let me get you that information later on. If you happen to be in the Los Angeles area or in California and you're interested in going into one of these tubes, and we'll scan your brain, we would do an intervention. I think the research facility we might use is in Los Angeles. So if you're interested in that, great. It would be just a simple intervention. It's a randomized control trial. So there's a 50% chance in that study you will get a placebo. You won't get anything. You'll just travel down, go into a tube. You won't even get a treatment. That's possible. We'll do pre and post. And we have another study we're working on, which is also a randomized control trial. So you can reach out to us. You can email us, but we can talk more.
All right, thank you. How do you respond to those who say we are denying our true selves and we are just in denial?
Who determines what your true self is? What determines it? Your thoughts, your feelings? What determines it? We could say that for anybody. If a man is married and he loves his wife, but he finds another woman attractive, do we say, well, that's just your true nature? Your true nature is that you're promiscuous and you just need to embrace it. You're just suppressing these other desires, or maybe a person who's dieting and says, well, I shouldn't eat other food. Well, you're suppressing your real desire. We could say this what is our true self? What is the core? What are we going to let define us? Is it our desires or is it our values? And that is a fundamental question. That's a philosophical question. That's a metaphysical question. And I don't think that a therapist can ultimately, impose that on the client. For many men, and many men say this, they'll say, look, I identify as gay, but obviously my body is wired for heterosexuality. Every 24 hours, a healthy male is producing 100 million sperm cells, and they are all 24 hours a day looking for a female egg cell. They'll be propelled toward it. The estrogen, the progesterone, draws it, it activates them. So is it fair to say that everyone, or virtually everyone, is part heterosexual? So that's a philosophical question.
Absolutely. Our bodies are designed in a certain way to then see if the mind is then aligned to the body. How are we for time? I don't want to burden you.
I can.
Okay. What is the most effective way of accepting ourselves as men and completely masculine internally and externally? The most effective way of accepting ourselves as men.
Of what, ourselves as men?
Accepting ourselves as men.
Accepting ourselves as men? I think there's probably two ways. One is spiritual. If a man has a spiritual experience with his creator, I'm not saying any specific religion, but it's like, wow, this is there's a plan for me and I have a design and I'm meant to be in this body. Like, I think there's a spiritual component that should be dealt with in a spiritual way that's outside my area of focus. Another area of powerfully internalizing that is being in the presence of a man who you trust, who affirms you as a man, and you don't resist it, but you just let it in. Like, stop. So many of my clients resist it. Let it in. When a man affirms you, that I see you as a man among men, to breathe that in, to breathe into a space around your heart, to allow in the good feeling. Don't intellectualize, don't dismiss it, don't disqualify yourself, but stay here and now in that acceptance moment. To let that in, that is powerful.
Beautifully said. Thank you. Is there reintegrative therapy for Portuguese speakers?
We're working on it. We're working on a Portuguese video right now, and we are working on training materials. We're going to go Spanish first, and then we want to do Portuguese after that for training materials for therapists. So hopefully, if all goes according to plan, you can reach out to us in a year or two, let's say 2, and we should have some therapists trained in Portuguese. So we're working on it.
Thank you. Another comment saying excellent presentation. Marlene, thank you. Another comment, connection between SSA and childhood in terms of same-sex molestation. So how often do you see that in terms of child sexual abuse in your clients? How common is that?
33%. So 1/3 of my clients were sexually abused when they were young. resulting in conflict and confusion and same-sex attractions. This is another reason why, if they try to ban this therapy, you're banning options for sex abuse victims. Many people can say, I can point to a specific moment in my life. There was a filmmaker who did a documentary on reintegrative therapy clients. And the documentary is called Free to Love. And if you go to reintegrativetherapy.com, you'll see Free to Love. In that film, the filmmaker went to the LA Gay Pride Festival. And I was actually, there was one part of that film that I was with him in it. I was away from everything else. It was all independent of me, but he asked me to come along. And outside of the Gay Pride Festival in LA, we just started asking people with a microphone, people walking down the street, excuse me, how old were you when you were sexually abused? And we just handed the microphone. I mean, I thought I was going to get punched. Like a third of people walking down the street would say, oh, I was 8, I was 13. These are strangers. Wow. 1/3. That is exponentially higher than a random sampling. There, people went, well, I don't know. Well, I don't know if you call it abuse. There were kind of a lot of these answers. Well, I don't know if it was abuse, but a third of people. And so you'll see films, as you'll see scenes in that film of guys wearing the gay headdress and all this stuff. And they're going, yeah, that's one man said something like, that's probably why I'm here. Like, yeah, like it's just, there's, so to answer your question, about a third. That was a long answer to a simple question.
No, it's so common, isn't it? So, and it's not talked about in those communities. So thank you. I wonder if you also measure the internalized homophobia of the clients. Is it possible that level of internalized homophobia is the one that facilitates the change of sexuality and byproduct of therapy? Internalized homophobia.
Okay. Well, if that were the case, then the majority of people going through this therapy would show significant, well, I'm thinking statistically, I'm answering that question statistically. Where my mind goes when I hear that is there an internalized homophobia scale? How valid is it? I'm thinking of it as a clinician, like, is there a comparison group? So I don't know of a good scale to measure that, although OCD can sometimes be in some cases, HOCD kind of functions as internalized homophobia, a profound fear of one's own homosexual thoughts and terror in some cases. So in that way, it kind of functions in a way that's not discernible from internalized homophobia. So we have to treat OCD. We have to treat OCD early on if it's playing a significant role. And so, the answer is it depends. But, I think some people on the right would say, oh, there's no such thing as internalized homophobia. But they can get on board with, well, there is a such thing as OCD where you're afraid of your own homosexuality and you build your life around it. I mean, I can think of men, I'll give real life examples, how some would call this internalized homophobia. I would just call it HOCD. But a man who was totally afraid of being around people who were gay. Totally. If the guy seemed gay, he had to get away. He would not wear the color pink. Nothing could be pink. He avoided Starbucks coffee because Starbucks coffee was like kind of had a reputation for being pro-gay, and he didn't want to be even seen around that. It turns out that was just OCD. And part of his OCD treatment was to wear a wristband that was pink and to go to a Starbucks and get your coffee from there. And if a guy was gay at work, treat him like anybody else, don't avoid him. And over time, he overcame that. So anyway, I hope that's helpful to the person asking the question. That's my reaction.
Yeah. I think in both gay affirmative therapy or, like safety or whatever, in both cases, we're encouraging the client to not have shame, right? So it's like we're in a culture which is ashamed about having the same sex attractions, and the work is bringing the shame out. In gay affirmative therapy, they're coming out as gay in a change allowing therapy, they're coming out as where they want to be going, right? What identity they want to be taking, and that's kind of up to them. So I think in both cases, the internalized homophobia is just a product of where we are in society, where people find same-sex attraction as a difficult reality. So thank you. The question is, does it matter if the therapist is male or female for clients?
For EMDR, for trauma treatments, and for OCD, usually it doesn't matter too much, but it really does help a client who has the deficit in his own sense of gender identity to be affirmed by someone of the same sex, someone who says, I see you, I see your weaknesses, I see your strengths, I see your shame, I see your fears, and I see you as an equal. I see you as belonging to the same group that I belong to. I see you as, that's powerful, powerful stuff. And a female therapist can't give it to a male, and vice versa. A male therapist can't give it to a woman. I have some women with same-sex attractions, not presently, but in the past, and they hunger for a woman to love them and see them as, the word I want to use, cherished, something a lot about like cherished and delighted in, and I can't give them the maternal nurturance that they hunger for. And a female therapist would be probably better suited to that.
Thank you. There is emotion focused therapy for dealing with fear and other emotional stocks. Can this help, or emotion focused therapy?
I can't answer it because I'm not as familiar with its effects. Sorry.
Thank you for your work, Dr. Nicolosi. As a Muslim who used to see one of the therapists you are training, I found my therapist, a white male, could not understand the additional shame component which comes from being part of a minority Muslim population in the USA. It would be good, more effort would be done in this aspect. I have to say, working, because I work within the Muslim population, that the differences between maybe other types of population is that there is still a huge amount of shame of same-sex attraction within the Muslim community, where they, say in the Christian community, they will have people who are coming out and saying, hey, I'm same-sex attracted, or hey, I'm gay. Whereas in the Muslim community, it is still very much a taboo to even have this or even talk about this in that sense. So I guess what the question is kind of asking is for more maybe cultural awareness or something like that.
Whoever is writing this, feel free. I invite you to send me an anonymous email. I don't need to know who you are. It's not important. And let me know the name of the therapist. And my commitment is to talk to that therapist about that. I think that's really important. That helps the therapist. You're actually helping the therapist. And most importantly, you're helping other Muslim men who might be in therapy with that therapist right now. So I don't need to know who you are. It's not important. But if you could let me know the therapist, I would invite, I'm not here to shame the therapist, but I want to know, and we want to grow. And so I think that's important. So thank you for bringing that to my attention.
Thank you. How to differentiate exploring heterosexuality from wearing a social mask to be accepted? So I guess that's saying, is that not a social mask if I'm exploring heterosexuality?
Okay, so gosh, I even have a graphic about that because other people have asked me that question. Let me, so the I don't have it with me, but let's acknowledge that there are external factors and internal factors that a man would have to explore heterosexuality, and not all of them are internal, not all of them are external. So societal pressure false societal expectation that if you are heterosexual, you're going to have a perfect life and you're going to have, everything's going to be great for you. So there are these assumptions that could be made on one hand, and also many of these clients are internally motivated. I think the answer is in your body. When you ask yourself the question, why am I doing this? For anything, why am I doing this? If you practice connecting to your body, that's internal data. That's not coming from the outside world. What is going on? When I think about this person, do I feel any pull toward this person? Do I feel an openness in my heart? And that takes practice. But body work is a great tool at distinguishing, am I doing this because I want to do it, or am I doing this because people are pressuring me? Practicing that will help you get clarity on that. And every man's story is different on that question.
Absolutely. We find so much of people pleasing in our clients, or trying to conform to some type of social norm. Checking with you on time, Dr. Nicolosi.
Great.
Okay.
I can do 15 more minutes.
Okay, 15 more minutes.
I'll try to talk faster. Sorry.
Okay.
Sorry.
I had no relationship with my father, and I had no attachment to an older man, which I think explains why I get attracted to masculine older men. My situation does not involve an explicit trauma that can be treated. How do we repair the attachment loss to a masculine figure, especially that is almost impossible to find a person who is willing to act as a father figure to a fully grown-up man?
Okay, so I think I'd like to take that and make it two parts. So the first part is, how do I deal with that? So many men come to me with that same dynamic that you described. And when we do a reintegrative protocol, it leads them back. So they get the image of the older guy, the ideal older guy, the father figure, and they kind of get into that fantasy and they really get into it. And oftentimes it's sexualized, right? So they think about the peak sexualized moment, then they go outside themselves, they look in their own eyes. This takes guidance with a trained therapist, but they will usually spontaneously look in their own eyes and see early memories of being alone, and not having that connection, neglect. So trauma is the presence of the negative. Neglect is the absence of the positive. Let me say it again. Trauma is the presence of the negative experience. Neglect is the absence of the positive experience. And for this individual who asked this question, he might have just had a lot of neglect. I didn't get the warmth I needed. And so a lot of mindful self-compassion and EMDR can be very, very helpful at healing some of that. So that's the first part. The second part is something that you said at the end. You said it's almost impossible to find a person who's willing to act as a father figure to a fully grown-up man. And I understand, to be a fully grown-up man and look for a father figure is hard to find. But I like how you said it's almost impossible. It's not impossible. So a religious figure who is older, who's there for you. There are other men, there are benevolent men. So trying to find other men who give you the 3 A's, male attention, male affection, and male approval, who invest in you and want to get in your world, that is important. A therapist, an older male therapist could be great. But those are some of my reactions and thoughts when I hear this. But don't give up. And neglect is harder to treat than trauma, I think, but it can be done with enough patience.
Thank you. There's a comment, agree, SSA feels very unnatural, it's obsessive, it's about fear, it's too exciting, whereas OSA is more natural and calm.
So whoever wrote that, let me just say one thing, whoever wrote that, try an experiment on your own. When you see an attractive guy, don't look away, don't shame yourself, just notice that jolt. And if you go slow and you drop into your body, you'll probably notice the compression, the contraction, tightness in the chest, and genital jolt. And with the woman, it's more of an expansion, slow. And you'll also notice that fear, anxiety. Oh, can I share my screen? Is that okay? Okay. Let me just grab to this person who asked me this question and to anyone else. I just think this is important for all of us. We share this. Here's a diagram. As you can tell, I like diagrams. Okay. So we have our we have our inhibitory emotions on the left. Inhibitory emotions are anxiety, fear, and shame. And in your body, it's a contraction, cold in the torso. That's about avoiding something negative. That's what anxiety, fear, and shame are. They're priming survival responses of getting away from something negative. And the expressive emotions are a warmth or expansion in the torso. Anger, healthy anger, sadness, and joy are expansive. It's about seeking something. Even anger and sadness are about seeking. I'm seeking to be understood. I'm seeking to set a boundary with you. I'm seeking to come to terms with a loss. Okay, that's openness. They signal openness. Even anger, when it's healthy anger, can build up relationships. And it's about there's vulnerability about, hey, you really hurt me. So when you are in the, when we, all of us, feel the expansion in our chest, it's usually when we are priming an emotion that could move us toward a secure attachment style. So anything that is a constriction in your chest, you're not entering into the secureness of yourself. You're not seeking something in vulnerability. So there's a distinction there, something for you to know, for us all to know.
I love how it's so related to somatic experiencing and how different emotions appear in the body, and analyzing the differences between that. Thank you. Do we need to reveal our SSA to all male friendships to heal, or only some?
No, not all. Only with men who you trust. You shouldn't do it with all. So in shame and attachment loss, this is broken up. This discussion is broken up into 5 parts. So how do I share my SSA with another man? So 5 parts. 1 is talking with the other man about your childhood. This is the kind of mother I had. This is the kind of father I had. These are the experiences that left me. So really actually just focus on mother and father, or brothers and sisters, and talk to that other man and see if the man gets you. If he can't get that, that's not good. It's not a good sign. But most men can understand that. From there, you move to the second, which is the results of the family background. You say, as a result of having my father and my mother and my brother like this, my brother bullied me or whatever it is, this is what it left me with. I felt inadequate or ashamed or isolated myself. And then you want your friend to understand that about you, to give your friend an opportunity to understand that. Third is same-sex exploration. As a result, and by the way, if he's gotten through steps 1 and 2, he's probably going to be okay with step 3. Yeah, an immature guy or a shaming guy, you'd probably know by this point in the discussion. But if you said, yeah, as a result of this, yeah, I explored, I explored homosexual, gay, not gay, you probably don't want to use that word, but I explored same-sex touching and same-sex sexual experiences as a part of my journey. But I realized this doesn't represent who I am. It doesn't leave me fulfilled. It's not the direction I want to go. It doesn't reflect my values. And then you go into step 4, which is healing through authentic friendships. What I did learn is that through male connections, that's what I was really seeking. I was seeking connection and to be equal with other men, to be known by other men. That's what left me more fulfilled. And our relationship is a part of that. And then the optional 5th step is accountability. Hey, can you talk with me about this from time to time and ask me how I'm doing in my struggles? So the 5 steps in order, they could be done in all at one time or in 5 different conversations. Early attachment figures, results of those relationships in you, same-sex exploration, healing through authentic friendships, and the 5th optional step is accountability. All of these are mentioned in Shame and Attachment Loss. The chapter is authentic male friendships, it's called.
Male friendships. I love that because we've used it. We've used that model with our clients. It's the most commonly asked questions. How do I tell another guy I have this? How do I build it? And we have a PDF on it, and we've used it so many times. So thank you for that really beautiful explanation of it, and it's really useful. It's the same as telling a spouse. People also think, okay, how do I tell a spouse? And as it's written in shame attachment loss, you start with the childhood issues, and then you go, because if you just say I'm same-sex attracted, that sends a very different message than taking the person on the journey, as what you've just said. Thank you.
Yes. Can I share my screen real quickly? Someone asked a question. Make it really quick. Someone asked a question about trauma and gender identity. So here's that study. I think it's available for free online. I think attachment patterns and complex trauma in a sample of adults diagnosed with gender dysphoria. This is it's done in Italy, Italian study, and way more trauma. I mean, including physical violence in these kids. But certainly more trauma from these individuals. Abuse, there we go, psychologically, physically and psychologically abusive fathers. And many of these fathers were clueless. Like, it's not like they beat up the kid because he was effeminate. The kid became effeminate partly because he was beating up the kid, physically beating up the kid. And if anybody is ever unclear about, well, wait a second, are these kids effeminate because, is it a cause or a consequence of that paternal relationship? Is it that these kids were just naturally more effeminate? That's who they are, and so the fathers are jerks and they beat up on these kids, and that explains the health disparity, the psychological health disparity? Or is it the other way around? Is it that the psychological trauma causes the disidentification? And that's what. So if you are interested in that topic, because this has been a long debate going on for many years. Someone a woman dedicated her entire doctoral dissertation to doing this. Sherry Golden, I'm going to put I'm going to link to it right now, share my screen. Sherry Golden did work on the fathers of these men and did the best statistical method she could have done to tease out, is this, this is done in the Journal of Human Sexuality. Let me scroll down. Let me look for Golden's article, page 147. Sorry, bear with me. There we go. The relationship between father involvement and father role confidence for the fathers of gay sons. This was her research. And she administered these well-known psychological assessments. And these men, before the child is even born, they feel less confidence. They don't feel secure in themselves with having boys. So anyway, if you're interested, the work is Sherry Golden, and you can look up some of her research online.
It's amazing how the research, and especially complex trauma, we do also see in the population that we see, there's CPTSD, there's complex trauma, which is very common in the clients that are coming in. And a lot of, especially with gender dysphoria, there's a lot of complex trauma. There's high degree of suicidality in this population as well. And somehow all of this is ignored, or, it's just said, no, social acceptance is going to fix everything, and so on. So, and you're right, it's the argument of, no, trauma is already, it's not trauma-induced issue. It's just it happens to be that there's trauma, and I know that is a contentious issue among this work. Mm-hmm.
Can I share one more? I know this is super nerdy. I mean, I'm just giving you. I know it's nerdy. But it's interesting. This is interesting. So there's a whole study, Ali, on what you just said, okay? The most expensive study. This is $1 million study we're looking at easily. Minority stress, distress, and suicide attempts in 3 cohorts. They looked at people. So, I mean, we're talking about people born starting in 1974. They went back to the 50s. This is a half a decade. Actually, it's close to 60
Wow.
years of work. And they looked and they say, we've done all this work on societal acceptance, and we looked at gay kids in the 50s and today. Now you think after all this stuff in America that we've done, that they'd be much better off. Their suicidality would be lower. The violence done against them would be lower. No, the suicidality is even higher after all this work. And so the authors did this. I mean, this is a multi-generation study. And the final paragraph, they basically say, yeah, I mean, the kids are worse off after 50 years. I guess we have a lot of work to do. And it's like, that's how you end the study. That's how you admit that like your hypothesis probably failed. I mean, that's shocking. So anyway, that's the generation study. Off the charts.
We still see it today. You know, I've asked so many guests which come in. We had even with gender dysphoria, we asked the same question: is it minority stress theory? And it's the same response back that no, it's a very bad theory. And it you know, if that were true, then we wouldn't have these issues in you know, like Scandinavian countries or countries which have been like really accepting, and you know, they're still showing issues in this population. So absolutely. Therapy, last question. Therapy may not be possible for everyone due to financial reasons or otherwise. Also, it may not work for everyone. In your opinion, what other support options for men with SSA who want to live in concordance with their values and not act upon their SSA?
There are all these groups popping up, and I don't know the effectiveness of them, but there's groups online. Of course, we have something, you know, that's helping so many people. We have strong support. But honestly, friendships are free. And so being with others who really affirm you, who know you, who you're not. So intimacy is knowing and being known. That's intimacy. And my clients are much better at knowing others, but they're not as good at being known, at self-revealing things about themselves. So developing intimacy in your friendships and making a point that when you are with other people who you want to connect with, and for many of my clients, that's people of the same gender, that's where they want to grow, taking the time to know the other men deeply, but to also take risks in vulnerability and letting other men know them deeply, their shame, their confusion, and going into those friendships ahead of time. Like if you're going to hang out with your friends, know ahead of time, my commitment to myself is I want to share one small thing that I haven't shared with this other person. It could be very, very small. I struggled with pornography this week, or here's a part of my body I just don't like making a consistent effort with men who do this. And they may not all reciprocate, but if you have a consistent pattern, by the end of a year, you're going to have much deeper friendships, or you'll at least know which are your good friends and which are your superficial friends, because the good friends want to know more, or they'll share about themselves, and the superficial friends just don't really know what to do with it. But patterns of vulnerability is free and profoundly healing when you're with the right people.
Absolutely. I think that's such a beautiful way to kind of end the Q&A in terms of one of the things that we find in support groups more often is people saying, oh, you know, I spoke to this guy, he's straight, and he had the same insecurities that I do. And it's like, oh, and it's like, yeah, because he's male as well, and we're both males, and every man has insecurities. And I think it's, for a lot of this population, they've been told, oh, you're gay, or even you're same-sex attracted, so you're this other little thing. But when they actually talk about their vulnerabilities, they share and they open up and they realize, oh, so it isn't just same-sex attracted men who have these issues. Other men have go through the same issues and stuff and so together. And so that inherent difference, feeling different or feeling other than, that goes away through these friendships. And you know, I love what Dr. Nicolosi Sr. he says when he talks about the reparative drive. He's saying that the sexual enactment is really a healing drive for that inner conflict. You know, it's the body is trying to repair itself in a way that it knows how to do that through that connection. And it's because we see men, when a man is naked, he's in his most vulnerable state, right? There's nothing more vulnerable in that state. And through seeing another man vulnerable, if we can see another man vulnerable through a friendship, you know, through discussing our insecurities, then we're getting the same lovely experience of sharing vulnerabilities, but it doesn't need to be through sexual enactment. So I think what you just said there is so true and profound. Mm-hmm.
Thank you. Thank you. Thank you for being. I really appreciate it. I'm so good. We met in Hungary. We met for a little bit, right? You had the booth there. I was really impressed with that, and I saw your heart to serve other people and to be there and to put yourself out there. Speaking of vulnerability, to stand there with a booth, and so I appreciate, and I know every other person in this group is appreciative of your vulnerability. So thank you, Ali. You help set the tone. I think your vulnerability leads in this group. When you are vulnerable, I think you make it easier for the other men to ask their vulnerable questions. And also, I think it's your vulnerability paired with, you also have like something where you really want to you want to turn toward truth. You have that, I don't know what the term is for that, but you're like, you want to turn toward truth, even if it feels uncomfortable. And I think those two things together are like the perfect way of setting the tone in this group. So thank you.
Well, thank you. You know, I've like I said, my journey towards this was through your father's work, through your work, which was like, oh, there is actually science behind this. There's 100 years of psychoanalysis, which is just being thrown down the bin. You know, and it's amazing the censorship and, you know, the type of struggle we're just facing, and that, you know, we can connect on this issue on a human rights front, and then say that it's okay. And I really wish we reach a maturity in this sexual and gender debate, which says, you know what, whoever you are, whatever spectrum you are in, it's okay. And it's not a war anymore. It's whoever you want to be, wherever, you know, where you want to go. And I think hopefully maybe one day we have the maturity within this debate to say, as long as you're happy, as long as, you know, kind of, and we're not like banning each other or, you know, having these kind of very divisive type of work. And I, you know, like, there's so many people who reached out to me and they said, oh, I'm so glad we're having this webinar, and they're so looking forward. And I'm sure I'm even getting comments now in terms of your time. And I know the effort that you put in, your team puts in, people who we don't see. The videos are fantastic. I've seen them in Odyssey. I really recommend people to see that, you know, and the people who have been vulnerable and to come forward in the documentary, in the filming, to put themselves forward for this as well. You know, I want to appreciate all that work as well. And yes, and if you're watching and if you're seeing, please do contribute to Dr. Nicolosi's work. And I think it's important that we do give platforms like this for work like this, which is doing the research, which is being ethical. I think it's really important that we do this with ethics, we do this with science, as you've seen the research, Pila and Sutton study, Rosick and Nicolosi study, that this is research, this is scientific research. This isn't just something which is, oh, it doesn't have basis. No, this is real research which is happening. So, there's, I always see where there's reparative reintegrative therapy, I see that as the forefront of this work. So from the team at Strong Support that you don't see, from myself, I really want to thank you. If people want to know more, if they want to connect to you, what's the best way? If they have, I know there's some, you went through almost 50 questions, but if there's more questions today, how do they reach out to you?
They go to reintegrativetherapy.com. You can reach out to me there. There's a contact button there. We have plenty of resources, plenty of videos. And if people are interested in being participants for studies, we have some, there's different studies. You don't have to be in California. But we have a variety of different opportunities. So yeah, reach out to me. That's the best way to connect.
Lovely. Well, thank you so much for your time on this Saturday. Thank you, everybody who've asked their questions and engaged. And yeah, God bless.
Thank you. Thanks.